Hello, everyone. Welcome to our Advances in Autism Research and Care webinar. We're thrilled to have you. Welcome back after our brief December break. Thank you all very much for coming. Before we get started and introduce our presenter, I would like to just go over a few housekeeping reminders. First is that this webinar will be recorded and then uploaded to our network YouTube page. So if there's anybody you know who is unable to attend this live webinar, they'll have access to the YouTube link, which will be sent out after the webinar. Secondly, if you have any questions for our presenter, there is a questions box option in the doc on your screen. If you have questions, you can send them. I will collect them, and then we will present them to the presenter at the end. So without further ado, I would like to welcome Donna Murray. She is the Vice President of Clinical Programs at Autism Speak. She'll be introducing our speaker for today.
Hi, everyone. Welcome to today's webinar, Setting Priorities Among Autistic Adults to Develop a Research Agenda to Address Healthcare Outcomes. We're really fortunate today to have Dr. Teal Benevides present for us today. She works in collaboration with Stephen Shore, and unfortunately, Dr. Shore is not able to join us today, but we're thrilled that Teal was able to take on this presentation for us. So Dr. Benevides is an occupational therapist, researcher, wife, and mother. She joined Augusta University in the Department of Occupational Therapy as an associate professor in May of 2016 and maintains a joint appointment within the Institute of Public and Preventative Health. Dr. Benevides' research focuses on fostering access to services and supports for individuals on the autism spectrum. In the past 4 years, she's received more than $500,000 in funding from HRSA, PCORI, and the American Occupational Foundation. She works with community partners and researchers on the autism spectrum to build inclusive and respectful teams to address the most pressing challenges faced by the autism community. And I was very fortunate to see a poster by Dr. Benevides and Dr. Shore at PCORNet, and I was really impressed with her work. So I'm sure that you will very much enjoy the presentation. Thank you.
Thank you so much, Donna, for that introduction. Please let me know, can you hear me? Can everyone hear me, or can somebody give me a signal that you can hear me before I move on? Well, I'm going to assume that everyone can hear me. My name is Teal Benevides, and I'm excited to present this work on behalf of Stephen Shore and our collaborators, Alex Plank, Patty Duncan, and our Asset Community Council. I'll define and share with you a little bit about Asset in a moment, but first, I want to declare that we have no conflicts of interests in this presentation and the work that we have done with the Patient-Centered Outcomes Research Engagement Award. This funding allowed us to conduct our project entitled Autistic Adults and Other Stakeholders Engaged Together, otherwise known as ASSET. And the views presented in this presentation are solely those of our project team and are not those of PCORI, its Board of Governors, or its Methodology Committee. So I don't think it's a surprise to anybody who's attending today's webinar that autistic adults have multiple chronic and potentially preventable healthcare needs as compared to same-age adults without autism spectrum disorders. I should first note before I continue that I'm using the term autistic adults purposefully as identity first language, and I will be using it throughout this presentation as the preferred term of our project team, and I'll explain a little bit more about that. But for those of you who are familiar with person first language, I did want to provide the heads up in case it's a bit of a shocker. To continue on, we know that individuals on the spectrum experience health conditions across the lifespan, although unfortunately, as noted by the IACC in 2015, research across the lifespan comprises less than 2% of all funding in the United States. And unfortunately, the individuals on the spectrum have similar lifespans as all other individuals, but experience very few services and supports as they transition to adulthood and living in adulthood as workers and contributors to the fabric of our society. So at the present time, we have very little research and supports to address lifespan issues. The biggest question remains, though, as to what is important to address across the lifespan. So in the research literature, we know that Liz Pellicano and her colleagues in 2014 examined healthcare priorities and even beyond healthcare, just priorities of autistic individuals living within the UK. In addition, she and her colleagues examined the priorities of immediate family members, professionals, and researchers. This research was fundamental to beginning the discussion about what autistic individuals and their family members find important for future research and practice. However, we do not know what the priorities are specifically from autistic individuals living in the United States, which is a very different healthcare system. And additionally, Liz Pellicano and colleagues had a very minority group of autistic individuals contributing to their stakeholder project. We have a fundamental need to ensure that autistic individuals are involved in setting the priorities for lifespan research, that type of research that will involve and incorporate their preferences and priorities to address topics that are necessary for achieving optimal well-being and health. So therefore, we sought to understand the research priorities to improve health and well-being across the lifespan. Our project, which was a 2-year engagement project funded through the Patient-Centered Outcomes Research Institute, was to meaningfully include and engage autistic stakeholders in answering the following questions in preparation for future comparative effectiveness research studies. First, we wanted to know what the health research priorities as identified by autistic adults were. So we aim to focus specifically on health research priorities because of the very poor health outcomes that are experienced by individuals in the United States and beyond. Second, we also wanted to identify what preferences for engagement and participation in research practices as co-partners and co-developers as research during the research process. So what were the methods and experiences that individuals had when participating in these types of co-developed research activities? We're going to focus the first part of our presentation on the health research priorities as identified by autistic adults. And second, we will then go into the preferences for engagement and the methods that were found to be most successful. I'll be presenting on behalf of Stephen Shore, who usually presents on the preferences for engagement and the methods. And I'm again apologizing on his behalf. He wishes he could have been here to present this content. So in this process, we used a participatory action research design to establish a project team comprised of autistic and non-autistic individuals. Both Stephen Shore and myself were the project co-leads, and in this role, we fostered all of the day-to-day activities and administrative aspects of the project and coordinated organizations, community council members, and others in the planning and running of this project. Also on our project team was Alex Plank, who is well known for his work at wrongplanet.net, as well as his TV and other media appearances. Patty Duncan was our meeting planner and helped to coordinate and run the large-scale meetings in which we invited stakeholders within and across the autism spectrum and their family members. We established a paid community council of autistic adults and other stakeholders to inform and guide our participatory research. These 18 community council members joined and contributed during the 2-year process, and about 14 of the 18 identified as autistic. These community council members lent their expertise to every project decision that was made and helped to debate and discuss the merits of different aspects of the project before we acted on them. Throughout the 2-year period, we involved other stakeholders, both individuals and organizations, in the priority setting activities, and we'll briefly discuss those as we move forward. I do want to emphasize the importance of our community council in our participatory research project. So, as I mentioned previously, all actions during the project were planned, discussed, reviewed, and ultimately approved by the community council. We used a majority opinion to move forward on all project activities, so that we first discussed all options, either through a Zoom meeting, through Facebook chat or Messenger, and through email. And then we emailed out decisions to be made, and all members voted to share their opinions about next steps. All questions for surveys and focus groups that we are going to describe were trialed, revised, and ultimately reviewed and approved by our community council members. This helped to ensure that all of the activities we engaged in were appropriate and acceptable to the autism community for which we were hoping to involve in understanding the priorities and preferences. In addition, we felt it was incredibly important to ensure that all consent forms, flyers, and meeting documents were reviewed, revised, and approved by the community council. This involved extensive collaboration with our institutional review board, who didn't always understand the revisions to the language that were required by institutions from legal and other regulatory guidelines. And this was done so that we could simplify language, use bullets as needed and/or pictures in consent forms, so that all materials were easily accessible to members of the autism community before participating. Ultimately, all of the project activities were reviewed separately by our institutional review board. Some were deemed human subjects research and some were not. So over the course of our 2-year project, approximately 400 people engaged with us over the 2 years to provide their input and preferences for healthcare activities. We use several methods in order to engage stakeholders. In year 1, July 2017, we held a large group stakeholder meeting the day before the Autism Society of America conference in order to involve autistic individuals in identifying those practices that were felt to be helpful when used by researchers to help understand preferences and priorities, and those practices that were harmful to engaging in activities with the autistic community. We also did some preliminary priority setting discussions that allowed us to understand general or broad areas for future priority setting activities. We then used online survey methods and face-to-face focus groups to develop and understand specific priorities for outcomes and interventions and approaches desired by the autistic community based on that year 1 meeting. We used both online survey and face-to-face focus groups at the request of our community council, who felt that while an online survey would help reach a large number of people, we also needed to engage with people face-to-face to ensure that those who may not have access to a computer would have an opportunity to participate. Face-to-face focus groups did not require people to use spoken language, and all activities were able to be completed using written or assistive augmentative communication devices if desired. And then last but not least, we held a final stakeholder meeting in November 2018 to take the information we learned from our online survey and face-to-face focus groups and finalize the priorities through a modified Delphi approach to allow stakeholders to discuss the merits of different areas that were desired, and then rank order them for final discussion and presentation. So just a little bit more about the methods that we used. We used breakout sessions in our large group meetings with modified Delphi ratings using sticky notes to allow people to non-verbally indicate preferences for certain areas of action. Our online survey used Qualtrics, which is an online platform with multiple question types. Our final survey, after revision by our community council, contained 30 items, primarily with both closed and open-ended options to allow for people to indicate easily what their preferences were, but then also if there were no longer options that met their needs, an open-ended option to provide their input through that method. 15 demographic questions were posed at the end in case people ended the survey early. I'll show you some examples of what these items looked like. We tended to use visually driven options for people to respond to, since visual response options have been determined to be best practices for online surveys. Our focus groups, of which there are 3, involved 10 to 15 individuals, and first involved participants in discussing existing knowledge about health and well-being, leading to discussion of areas that participants wanted more information from research. People participated through writing on index cards, through AAC if desired, or through spoken language. And finally, ended in activities that allowed people to get up and move around the room to rank outcomes and interventions using sticky notes. As an example of our online survey, here is one way that we ask people to rank interventions that they would participate in future comparative effectiveness research activities. A list of possible interventions or approaches was provided on one side, and then people would click and drag their preferences for participation in that intervention or approach to one of 3 boxes. I would participate in this intervention, it depends, or I need more information before I'd be willing to participate, or I would not participate in this intervention. For outcomes, we asked people to click and drag outcomes that matter to me, outcomes that don't matter to me, or I need more information before deciding. For options that ask people to rate how satisfied they were with providers who provided services to them related to access to care, we asked people to give their healthcare providers, including crisis response providers, emergency room providers, and primary care providers, a grade using the United States scales and educational system ranging from A, a good grade, and how they interacted or provided services, to a grade of F. For our focus groups, you can see here how we had some visual infographics that depicted information about outcomes and other infographics that depicted intervention areas that people might want to participate in. There were also open-ended large sheets of paper that people could generate their own options that are not shown in this picture. People would use sticky notes to indicate their ranking of items. All rankings, both for survey and focus groups, were weighted to allow for comparison across multiple methods. Across the survey and the focus group, we enrolled a large number of individuals. There were no differences in mean age between the survey and focus group participants. In addition, we had no significant differences in Hispanic status or race between survey and focus group participants. However, we did identify that there were significant differences in gender between the survey and the focus group respondents. In our survey, a large number of individuals identified as non-binary, and these responses ranged in terms of how people self-identified their gender. In the focus group, however, people's gender was identified through their screening survey, which did not allow for an option to self-identify gender. And therefore, we have no individuals that identify a non-binary gender for our focus groups. Our survey also asked people how they were diagnosed. We did not confirm diagnosis with our survey responses in order to keep the responses anonymous and confidential. 182 individuals identified on the survey that they were formally diagnosed in childhood or adulthood, while 54 indicated that they had never received a diagnosis but were, quote, self-diagnosed. We chose to include these individuals because many studies of adults indicate that access to a provider that will perform adult assessment and diagnosis is difficult to achieve, and many adult studies include individuals who self-identify. While we don't have time to get into many of the important details of what we learned, we did want to discuss today the 3 areas of priority, as well as the specific research questions that autistic individuals identified as future areas for research and practice to address. 3 areas were very clear to us that were priority areas. The first was addressing mental health through interventions and outcomes that were deemed as important to the autistic community. The second broad area was addressing gender inequalities in diagnosis, treatment, and sexual well-being as an outcome. The third broad area that we heard time and time again in both the survey and focus group was to improve access to healthcare and improve needed accommodations for getting care. Individuals across the survey and the focus group provided examples of these things, and we'll discuss some of the open-ended feedback that we received that support these areas. For our first priority area, mental health priorities, we identified the following key areas for future research and practice to address. The first is, what is the impact of trauma on mental health outcomes in autistic individuals, and what approaches can be used to effectively address trauma among autistic individuals? We heard repeatedly from individuals that they experienced post-traumatic stress disorder or would like better measures of PTSD in autistic individuals. In addition, the experience of adverse childhood experiences, or ACEs, and the long-lasting impacts that these traumatic events may have had on adult outcomes were desired. Trauma-informed care was something that autistic individuals suggested was an area for future research, and understanding how the experience of trauma in autistic individuals may be different from those who are non-autistic was identified again as a priority area. Second, we repeatedly heard that the impact of social isolation, stigma, discrimination, and other forms of marginalization had on mental health outcomes and well-being. So many individuals across the survey and the focus group identified that these experiences throughout their lifetime, starting in childhood, resulted in their perception of self, self-identity, self-worth, anxiety, and depression as an adult. Conversely, individuals in our second large stakeholder group suggested that we frame this question as, what is the impact of radical inclusion, such as being a part of a social movement, on mental health and well-being? Framed in this way, the ideas around autistic identity and understanding what that means to be a part of an autistic identity and group has on improved mental health is something that has yet to be studied. Third, individuals participating in our 2-year project wanted to know when, for who, and under what conditions do self-managed interventions and preferred activities, how they're useful to address well-being and mental health. Specifically, individuals across the survey and focus groups talked about community available approaches such as exercise, physical activity, yoga, mindfulness, meditation, Tai Chi, animal-assisted therapy, art, and music-based approaches. Individuals participating in these activities identified that it was important to them to have access to these interventions and approaches in their community so that they did not have to go through a gatekeeper, such as a medical provider, in order to access treatments or approaches that they could use to self-manage their mental health symptoms and well-being. In our study, we wanted to note that we also conducted a systematic review to identify available interventions that have been examined among autistic individuals. Although there are systematic reviews on non-autistic populations for interventions such as exercise and physical activity, there are none that identify the effects of exercise and physical activity among adults for improving mental health. Neither is there anything for yoga, Tai Chi, animal-assisted therapy, art, and music approaches. There are some emerging practices that help identify the effectiveness of mindfulness meditation approaches, primarily conducted in other countries. In addition, the idea of self-managed interventions did extend to other approaches that could be taught and learned. So individuals highly ranked future intervention approaches to be studied, such as cognitive behavioral therapy, as well as peer-led support groups. And interestingly, the effect of cannabinoids on anxiety and mental health outcomes. So people in our project identified the need for research to address some of these approaches for understanding their effect on mental health and well-being in autistic adults. Participants also felt that there were very few studies that examined the potential long and short-term negative side effects or adverse outcomes of currently recommended therapies and interventions. So while there are recommended and evidence-based approaches in childhood, including behavioral and pharmacological approaches, autistic adults felt that the long and short-term negative side effects of these recommended therapies are poorly understood, and therefore recommended long-term and longitudinal studies to examine the adverse effects of these interventions across the lifespan. Because this is something that's typically done in pharmacological studies, we felt it was important to note that very little research has addressed these adverse outcomes for interventions conducted in childhood as measured in adulthood. And last but not least, autistic individuals in our project identified the need for better measurement tools to understand how autistic individuals define quality of life, depression, anxiety, social well-being, and sleep. These were the top 5 outcome areas that were identified through our survey and our focus groups. And the importance of measurement for research practices cannot be understated for understanding outcomes. At the present, very few validated measures for autistic adults exist, although many are in development presently. Here's an example of how different outcomes were rated on our survey. So quality of life was rated by a large number of our participants, as was anxiety, sleep, social well-being, and depression. Less frequently, but still rated as outcomes that matter, included interpersonal relationships, suicidal ideation and attempts, and participation specifically in work and activities of daily living. Things that tended to not get ranked and therefore are not on this list are physiological measures that often are addressed in biomedical intervention studies. Things such as heart rate or others that are used as indicators of mental health were not frequently identified as outcomes that matter to me. Moving forward, we found that there were several research priorities in which autistic individuals felt access to healthcare would benefit from additional research. First, autistic individuals wanted to know whether peer navigators or technology, such as apps frequently found on smartphones and devices, improve access to healthcare for autistics. Although telehealth was not always identified as a priority, the identification of understanding what peer navigators would have on access to care was desired. Oftentimes, individuals felt that they trusted their peers more than they trusted researchers or other providers, and therefore felt that more research to understand the effect of peer navigators would be useful for understanding access to care. Second, many individuals identified that transit and transportation was a barrier, especially when that transit was provided through a medical transit service. In addition, autistic individuals identified that community-based transportation devices or places such as trains or taxis were somewhat challenging and wondered how the use of non-medical transit such as Uber or Lyft might be utilized to help autistic people get to their medical and health appointments efficiently and effectively. In addition to transportation and technology and peer navigators, autistic individuals in our project asked how we could improve the communication between health providers and autistics to result in improved care outcomes. We frequently heard that communication difficulties between providers and autistic adults resulted in poor care outcomes, such as lack of attending appointments, such as miscommunication of symptoms and pain, as well as other poor outcomes. For example, when we asked people if you could change anything about getting healthcare, what would it be? People indicated that making it definitely easier to tell your doctor what's going on, primarily because it's so anxiety-ridden when you go to the doctor, would be an important thing to address. So tools that allow people to communicate what their signs, symptoms, and needs are, possibly using a non-spoken tool, was desired. Second, people didn't understand the recommendations always when provided to them verbally. One individual said, I'll get focused on one thing that's been told to me and they've moved on, and now, whoa, we're 3 steps down the way. I would like a written summary at some point, word for word. So the differences in preferences of communication between providers who tend to use verbal communication primarily, and autistic adults who prefer written or pictorial communication was seen in many comments. We also heard that providers' understanding of autism and presumption of competence in adulthood was something that was needed. So one individual said, I would wave a magic wand to stop doctors from treating me as a subhuman or a little child as soon as they learn on the spectrum. As soon as they learn I'm on the spectrum. We heard this from more than one individual, that adults felt that they were treated differently when providers learned they were on the spectrum and spoke to them as if they were a child. Also, individuals would preferred to have providers, adult care providers, understand autism better. So specifically, they noted differences in pediatric providers and transitioning to adult providers who knew very little. This is something that's commonly brought up in the access to care literature, but was frequently seen in our responses as well. The environment of care was an area of need, changing the way waiting rooms work, because in the waiting room with loud noises, smells, people wearing perfumes, lights, being taxing. One individual actually asked whether or not we could start studying the effect of those devices that we use when we go to a restaurant. When your table is ready, you have a device that lights up and buzzes so that they could wait in their car until their appointment time has occurred and the provider is ready to see them. So some innovative use of technology and existing practices was desired to change the environment of care. And access through transit and other approaches financially was deemed as a barrier to getting healthcare. Moving on, our third area of research priorities was related to gender and health. Specifically, many of our participants wanted to know how we can improve autism diagnosis in females and non-binary individuals on the spectrum. There was a perception that diagnostic evaluations and symptoms tends to underdiagnose females and women as compared to males. Although this is frequently brought up anecdotally, we yet to have any evidence that this is occurring, and although the priorities from stakeholders felt that this was in fact occurring. Individuals wanted to know how we can improve gender and sexual health resources to allow for better relationships between autistic individuals and for reducing rates of sexual abuse and trauma. So generally speaking, individuals noted that learning about sex and sexual health and well-being tends to occur in social groups during adolescence. They noted that lack of that learning could have impacted their ability to understand and manage their own sexual health and well-being as an adult, and wished that there were better gender and sexual health resources for allowing autistic individuals to express and understand their sexuality. In addition, the individuals who participated in our focus groups talked frequently about sexual abuse and trauma when relating experiences they had. And third, related to gender and health, was the understanding of how hormonal changes across the lifespan, going from early adulthood all the way up to late life care, affects the skills, abilities, and sensory systems of autistic individuals. Many people brought up their concern for the future as related to aging with autism. Specifically, they noted that they had found anecdotal changes in their sensory systems, which resulted in changes in sensitivities and their experiences of the environment, and wondered how that would allow them to participate fully as they aged. The understanding of aging autistic individuals is very, it's unknown, although there is some research that's ongoing in this area. Autistic participants wanted to know how these lifespan changes were occurring and how we might help them address these changes throughout their lifespan. In summary, we found the need to address mental health outcomes with preferred interventions to ensure outcome measures have been validated and reflect autistic adult priorities, that we need to address gender inequalities in diagnosis and treatment, as well as identity and sexuality, and improve access to healthcare. The limitations to our priority setting activities, we relied on a convenient sample of self-selected adults. Self-reported diagnosis was not confirmable for survey participants, and obviously was limited to those who had access to the internet or the ability to read and participate in an online survey. Although our online survey was composed of more females than males, and that's not similar to current diagnostic distributions, our survey was similar to other adult studies, especially those conducted in other countries such as the UK and other longitudinal studies in Australia. Future priority setting activities need to occur with individuals who do not have the ability to consent to participate on their own. For example, those who have a legally authorized guardian, with racially and ethnically diverse respondents, and individuals who are non-binary. At this time, I'm going to spend the remaining 10 minutes or so talking about preferences for engagement and the methods that we found to be successful when incorporating autistic adults as research partners in the process of research. In this 2-year project, we developed what we call an engagement and compensation guide. This guide is freely available on the PCORI website, and I'd be happy to send a PDF of this guide for your use if you desire to see it. I'll share a link to that at the end of the presentation. One of the goals of our project was to enhance engagement through the development of this engagement and compensation guide. And that guide had 4 sections: presumption of competence, compensation of autistic adults, a communication guide, and recommendations for measuring engagement in future research activities. We also developed a meeting information and accessibility guide that was useful in conducting our large-scale stakeholder meetings. This is not freely available on the PCORI website, but I'm happy to share it as needed or desired. Right now, we have time to talk about 3 areas of engagement and compensation and what we learned. First, Our community council and participants in our stakeholder activities felt there was a need for researchers to presume competence in all interactions. This extended to providers of care as well. So at the present, there's often a belief in our society that individuals who do not speak are less intelligent than those who do, and that those who do not have expressive language may not have receptive language. These are false beliefs. We specifically recommend, and this may be familiar to probably all of you, but was emphasized as really important for future researchers and practitioners to understand, that non-speaking individuals should be treated as if they understand all verbal language. In addition, attending to the specific types of language used would be helpful. Instead of sensory dysfunction, use the term sensory differences. Although the differences might impact function, aim not to describe the problem as being with the individual. Similarly, people did not like our use of the term comorbid conditions and preferred us to use the term co-occurring conditions when talking about other conditions that happened frequently in relation to being on the spectrum. In addition, our community council and participants in our project included the recommendation to teach students, family members, postdocs, and others to communicate with the person on the spectrum, even if they are a child. So not talking about the child or the adult as if they're not listening was a key component of our presumption of competence. I should share, by the way, that our engagement and compensation guide were developed and written by our community council members in relation to the things that we learned during this process of engaging in this 2-year project. So all of these sections were developed and written by our community council members, and those authors are mentioned in the PDF version. Our second area of this guide provides recommendations for compensation. The premise of this is that all individuals in research and practice should be compensated for their intellectual contributions. Many times, autistic individuals are asked to advise different projects or groups, and while the researchers themselves may be paid or on the project team, the advisors are not being paid for their intellectual contributions or are being paid a minimal rate. Authentic alliance and respect requires compensation as team members depending on the role. In our project, all community council members were paid $50 an hour for their time, which involved quarterly Zoom meetings and email communication, usually every month or every other month. We also conducted other Facebook chats or other kinds of activities, including in-person activities, and individuals were compensated for their time both in preparation for those meetings, during the meeting, as well as any post-activity requirements that we asked of them. Related to communication, we set out to understand best practices for our project team and community council. We want to make sure that everyone understands that each project team is going to be comprised of different individuals, and therefore these recommendations may not work for your team. However, overall, we aim to ensure that email, voice, and text communications were clear. Before every email was sent or any project activity was provided to the community council, Stephen Shore reviewed every single email that I wrote and edited it for clarity and reduced my excessive wordiness. We aimed at the middle of our first year to use an email template, which allowed for consistent communication across the project team and community council. This template helped to reduce the wordiness that I tend to use in my communications and allowed everyone to know what to expect. The example of an email communication template is provided here and is courtesy of Alicia Ashkenazi, one of our community council members. All emails started off with a purpose, which was bolded and underlined, and then each purpose was bulleted and very, very short. We provided details to our participants or community council members about what we wanted them to understand prior to their action. And then the actions were specific steps we wanted them to use with action verbs listed right away. We then included a deadline for action. Emails were always sent out with enough time to respond, They were never sent out on Fridays or weekends or holidays if that could be anticipated. And we usually used at least 2 reminders of our community council, one a few days later and then one just before the deadline. This helped tremendously in assuring that everyone had an opportunity to participate. We found, and people reported, that their executive functioning sometimes prevented them from participating as they wanted to, and that the reminders and the template were helpful for them in organizing their ideas and the steps that we asked them to take. So in summary, recommendations for engagement are to please include autistics in the development, implementation, and dissemination of research activities. Ensure participation through appropriate accommodation, presuming competence and focus on abilities in all interactions, value autistics as an integral part of the team, and avoiding tokenism or naming people just for the sake of naming an autistic collaborator. Allow for the presentation of research results in several modalities to accommodate different communication styles. An example of this is when we are preparing materials for dissemination, I would prepare a lay language summary, which was reviewed by Stephen, and then that was sent out to community council members so that all scientific materials were also conveyed through a lay summary as needed. And both versions were provided to all community council members. Compensation of autistics for their time and experience as the similar or same level as academic experience, and consulting autistics regarding priorities for research and systems change as we continue to understand and grow in our knowledge of preferences and priorities. So using principles of engagement is essential for best practices in research. Understanding and adapting the process of research took time, and it took a lot of energy. Many times research happens on a very strict timeline, and we found that our funder, Precori, was very responsive to our need to delay deliverables as we engaged the community. Our timeline, therefore, in future projects will allow for authentic alliance and ensure that we build in enough time to engage the community in all aspects. Also, we learned that focusing on the desired, preferred outcomes and approaches was essential from autistic adults who participated in our stakeholder-driven project. These focuses should emphasize strengths and incorporate these into treatment, emphasize self-determination and choices that allow people to control their interventions and approaches, and address mental and physical health. So I want to open it up with enough time for questions as well as discussion. I want to know how you might use these priorities to tailor your own research and or practice with autistic individuals, whether they're adults or children, and name one thing that you will do to take this information and use it or build on it in the future. I'm also happy to answer any questions or illustrate any parts of our project that were unclear. Thank you so much for your attention.
Hi, everyone. I'm just getting on here to send a reminder that if you'd like to participate in the discussion or to send any questions, you're welcome to send them in the question box, and I'm happy to read them out loud. The first question that we have for you, Teal, is, has this research been published yet?
That's a great question. We actually just recently received favorable reviews on our 2 publications thus far, manuscripts thus far, and they are both conditionally accepted for the journal Autism. One was submitted for the special issue on mental health, and we anticipate publication shortly, although I can't tell you when.
you. I've collected a few more questions with regards to the presentation. So the first question was, what do you see as next steps in terms of translating these identified priorities into research funding and future projects?
In discussion with our community council and our project team, we had 3 next steps that we were aiming to accomplish in the very near future. The first was to, again, disseminate what we learned, and we're doing that through our submission to peer-reviewed publications, as well as trying to share the word through lay summaries via our community council partners. In addition to sharing that knowledge, we also are identifying researchers who are engaged in doing work that may be already aligned with the priorities, either in pediatric practice, who might be easily able to translate it to adult practice, and contacting those researchers directly to share with them what we've learned. For example, there are a number of sleep researchers who have done work in sleep, and to share with them what we learned around mental health and sleep as priority outcomes and intervention areas. And so again, reaching out to specific researchers who might be able to take this information and use it to develop comparative effectiveness research. Also, in working with funders, we find that that's a critical next step, so that funders are aware of the need to fund priority areas that have been identified. So for example, working with PCORI, and we're glad to see that PCORI, for any interested people, have recently modified their strategic plan to include a new priority area, which are individuals with intellectual and developmental disabilities. So as of the beginning of January, PCORI's funding is now strategically aiming to address those with intellectual and developmental conditions. And so we feel that this research has impacted their planning and strategic plans for funding. We do need to work with other funders as well. And in addition, we would love any collaboration with others who want to extend this work. We obviously need to do more work with non-speaking individuals, individuals with intellectual and developmental disabilities, racial and ethnic minorities, to understand if the priorities are similar or if they're different. So more work to really understand the priorities is necessary.
Thanks very much. The next comment is an answer to a discussion question. I'm going to read it aloud from Brian B., who is a LEND alumni and self-advocacy coordinator at the University of Colorado Group and a self-advocate himself. He answered the question, how will he use this? And he said, I'm already working as a project manager under some PCORI deliverables, as well as consulting a colleague researcher. I'm likely to cite this during presentations and perhaps in writing upon further review.
That's fantastic, Brian. Thanks so much for sharing that. And our engagement and compensation guide is certainly available. PCORI recently notified us that they're going to publish it as part of their stakeholder engagement resources. We're happy, Lucy, to provide any updates on publication so that you could update the webinar with those publications should they be published in the near future.
Thanks very much. I think we probably have about time for probably one more question and one more comment. So I'll go ahead and ask the next question, which was, based on your findings, do you have any suggested strategies for clinicians for keeping these concerns and priorities in mind in the clinic?
That's a wonderful question, and I think probably would take more time than we have. However, I think that what we learned around presuming competence was essential. I think that oftentimes we don't recognize as clinicians, I'm a clinician as well, how our words and our language can impact those around us. So attending to strengths and focusing on those strengths throughout childhood, helping to support an individual's interests, maybe thinking about how we reframe what we consider to be quote unquote restricted and repetitive interests, and thinking about how we help that individual recognize those interest areas as potential areas for future work and social opportunities. And, you know, I think partnering with individuals on the spectrum to deliver care was something we heard a lot about, which is, you know, how are peer-led approaches effective? Although we don't have a lot of evidence on that, there's some emerging evidence from other areas that peer-led approaches are one potential way forward. I'll stop there.
Thank you. I also have a response comment from Brian, so thank you for sending that in, Brian, who said that his answer would be to involve self-advocates in person during clinical trainings and some assessments as consults. So thank you for sending that in.
That's a fantastic idea. Thanks, Brian.
Another question we had, Teal, was one topic that an audience member noticed that was not considered a top priority was self-injury and aggression. Did that come up at all?
That's a great question. We actually did not see self-injury and aggression come up as a priority area outside of the context of suicidal ideation and self-harm. Although non-suicidal self-injury is common, as identified by Sarah Cassidy and colleagues, it was not mentioned or rated as one of the top priorities in our mental health or other areas, although addressing suicidal ideation and suicide attempts was.
Another question, Teal, is, do you see a significant discrepancy between the priorities identified among autistic adults and the existing priorities of non-autistic researchers?
The answer is most certainly yes. In looking at the existing literature related to adulthood, there is a lot of work, a lot of excellent work going on around employment and around developing vocational skills, but not as much going on around well-being and quality of life. And although those might be related, I'd like to see more research about addressing the significant mental health concerns that were raised throughout our project period. And a lot of the funding that we see is addressing early screening, early identification, childhood interventions, biomedical and genetic advances. And those were not seen to be priorities by autistic adults, especially, and I don't want to marginalize any groups here, but they really did not feel that it was helpful or important to understand the genetic experience or the genetic component of autism, because there was a fear of trying to reduce autism, and as an identity, people felt that it was important to who they were. So I think there are some fundamental differences between what's existing in the funded research and what is going on. And I think that it requires more conversation for sure, but there are differences.
Thanks very much, Teal. I'd just like to share one last final comment from Angie Fideli at Autism Speaks. She just wanted to let you know that this was a phenomenal presentation and that they look forward to integrating the information you've shared today as they develop their self-advocacy committee. So with that, and in the interest of time, I wanted to say thank you very much again to Teal for a wonderful presentation. Thank you for everyone for tuning in. Last reminder that this presentation has been recorded and it will be sent out. The link to the YouTube page with this recording will be sent out following the webinar. So thank you very much, everyone, and especially thank you to Teal.
Thank you for the opportunity, and thank you all for attending. I look forward to hearing about what people might use this information for in the future. Have a great day.